So Dr. Abhijeet, can you just take it forward?
Thanks for the introduction. So I'm going to talk about some of the efforts that we have been doing, and this is pretty much in the initial stages right now. Conventionally, we are very used to using scanners like the Optical View, and there are others also in the market. Biotin is probably the only one that is commercially available with very high resolution, so you get almost 2.4 microns. With most of the commercials, you are around the 5 to 6 microns optical resolution. What we have achieved over here is going up to 1.4 microns per pixel in terms of digital resolution, and optically we are almost at 2.25. So what are the advantages of going for ultra high? I'm going to skip this part because most of you know about OCTs in general, but what we are pushing for is polarization sensitive optics. So light in general, has these waves. They are spread all around in space. But if we put a polarization filter here, we can selectively choose which waves pass through and hit the tissue. So what has been found is that when these polarized waves pass through lamellar structure like what you see in the collagen, the change in the polarization state of light occurs. And that gives us functional assessment of the status of the tissue. So this is possible not only in the cornea, but also in the retina you can achieve this. So for example, particularly RP and going deeper down to the RNFL layers, you get very nice status of the fibrous structure of the tissue. And it has also been shown in diseases such as AMD, where you can detect drusen much earlier than what is clinically seen in the fundus images. Okay. So this is what we are achieving right now. This is, all of you may have seen the Optical View scans, and this is what we are getting with our ultra high resolution. So you can see how clearly we see the Baumans layer, the epithelium, and something which I should mention here very nicely, that we have included some nice scanning protocols here. So the Optical View scan here is for around 6 millimeters of the cornea, and here we are scanning for almost 11 millimeters. So we do get some amount of the sclera here as well.
So just to read this is just the raw images.
Yeah.
So actually it can be, it's still, once the raw images is done, then the processing has to be done, and then only the quality, how you're seeing on the left, will be there. But in terms of structures, it'll be far more clear and defined in the image.
And this scan over here gives the status of the collagen structure inside the cornea. So if you have disease, early ectasia, keratoconus, or any other corneal pathology, we get very focal changes in how the collagen structure is oriented. The epithelium, as you can see, is almost clear because it doesn't have a fibrous network, and therefore it doesn't pick up there. So quantitatively, how do we use it right now? So this is the Optical View reports that you get. You get the epithelium thickness, you get the corneal thickness. You can see here that we are also doing the same thing, 52 microns epithelium stroma, and very nicely we are even imaging the Baumans layer, which is around 16 microns. Okay, so this one is going to be potentially very useful because there has been so far only one paper in the clinic where it has been shown that the Baumans layer thinning is a marker for early keratoconus way before you see manifest topographic changes. Okay, so this is a keratoconic cornea, and you can see that there is loss of signal over here, which shows the degradation of the collagen, and there are specific methods of quantifying that we are developing in our labs right now. This is an example of a keratoconic cornea. You can see here, 46, there is some amount of thinning which you see here, but remarkably in this patient, the Baumans layer is still normal. So these are very potent changes that you see, and how these changes are going to affect your treatment outcomes is going to be very interesting, because this patient obviously seems to be having a normal Baumans layer because the thickness is normal. So in case of keratoconus, advanced cases, they have found that the Baumans layer becomes thinner to the level of like 10 microns or less. So in order to measure those changes, you need this resolution, and you also have the, the endothelium here. This is an example of a keratoconic cornea, and here also you can see we are able to measure thicknesses nicely. Okay, so this is a post-SMILE case. Okay, this is 5 years after SMILE. Now, if you look at the Optical View scan, you can't make out much of where the cap is, and these are one of the disadvantages of doing post-processing, because it removes the details. Whereas if you look at the PS signal, you can clearly see this band here, which shows this SMILE gap. So once we have our post-processing software also ready, you will be clearly able to.
So that means there is no collagen in that area. You can just see the.
Well, there is collagen, but it is no longer in a stretched fashion. It is not in the same distribution orientation.
So actually, you will be able to define the layers where it is, and plus, if there's any kind of a reaction or this one, you can actually define where is it arising from. So this is something that is, I think, the first of the scans. Even the smile patient, keratoconus, whatever you're seeing, is one of the first which is ever taken on such a high resolution.
Abhijeet, can you just focus it on the Baumans there? Look at the wrinkles there. The Baumans layer, there's a lot of wrinkles. This is something which we never see, and a high resolution thing when there's a lot of wrinkles. It's something which is very unique, because we know many times the quality of vision and
so something very interesting.
Aishwarya is smiling, it's her eyes only. She's seeing all this for the first time.
Something very interesting, which is that the Baumans layer doesn't extend beyond the central 8 to 9 millimeters. It kind of becomes.
But look at on the polarization, look at that band on that thing, down.
Down this one?
Yeah, look at that band, which is still no collagen there.
So you will see this
doesn't heal at all.
Yeah, you see this clear distinction over here. The line, there is a band of missing pixels. This is the interfaces.
The blue and greens are all your collagen orientation. What we want to say is now, we actually did, you have the Smile Extra. We were always wondering what happens to Smile Extra, because this will be the real proof.
So again, we are only at the level of doing thickness quantifications now, but you can see, how much wrinkly.
There was a lot of wrinkles.
This is 5 years after Smile. So this is a post LASIK, and no
wrinkles.
Here also, you see the band, less wrinkles probably, very distinct differences in the way the collagen is distributed post-operatively. Now, all these implications are very new. Although polarization sensitive has been there for 2 decades, it has never made it to the clinic, for which I cannot give any explanations why the companies have not taken it up.
Abhijeet, can you just, in that polarization, can you look at the flap and look at the orientation of collagen on the flap and stroma? They're totally different. That is one of the reasons I think, your flap is not as different collagen than maybe, look at the flap is very uniformly just below the Baumans. No, not that.
This one?
Yeah. See, and just below that, and look below that.
Yeah.
And it's more of like a scarred picture.
I'll just go through this quickly. Okay, so this is a different set of images where, because we are looking at PS sensitive scans, we get information from multiple light channels, and these are some things that we are developing in the software that can give you more potent information about the collagen structure. This is a comparison of how, the only ultra high resolution which is available is the Biotin Scanner. It does a 3 millimeter scan, and here also you can see the Baumans layer quite well, but we are able to achieve the same resolution with a 11 millimeter scan, so you get much wider field of view. So overall, we are going to generate topographies also in the near future.
So Abhijeet, those white things you see are all the collagen bundles?
Well, this is the intensity scan. So this is not exactly showing the collagen. It is the retardation maps, which you saw the colored maps. That is the one.
Oh, okay.
Yeah. So this is.
Why can't you do it with the same retardation with the? Because that's not the polarized light.
Correct. Yeah. So. So he was talking about the Smile Extra case. These are, this is basically data from one patient. One eye underwent Smile and the other was Smile Extra. So now in the Smile Extra case, obviously there is a prolonged intervention. So you would potentially see a greater delineation between maybe the cap and the residual stroma. So my question to the audience is, there are 2 sets of scans here, here and here. Which image from these 2 is probably the Smile Extra case? And you can clearly see a delineation here because of differential collagen. And which one is the Smile? Any guesses? Is the top one Smile Extra or the bottom one Smile Extra?
Gaurav?
So just keep in mind, you see a clear cap here.
Right.
And the Smile Extra is a longer process. You are doing cross-linking also.
So see, I would put the upper one as the Smile Extra somehow. I don't know.
Why?
You know, so I was looking at few things. I was looking at the stromal, you know, a little bit of the dishomogeneity over there, and maybe the corneal thickness as well. I would think that Smile Extra would have some compacting, and it appears to be a slightly thinner cornea up there. And then at the interface, but these are just my guesses. I mean, you know, I'm not talking scientifically.
You're actually right.
Yeah, you're actually right.
What was very interesting for us is that we expected this to have that band there. We expected this to be, but what you said is right, because it is kind of, I mean, this is only one eye, but it may be trying to make the cornea compact like a glue.
That's right.
And here, that space there is not, it's just a space. I mean, we don't know. I mean, it's just too early to speculate, but...
this is just a hypothesis now, because we don't pick up these changes in the conventional scanners, the commercial scanners right now. And what we see is exactly right. I mean, it seems to be some kind of a gluing effect, so it doesn't pick up the interface that well. And these are the polarized light images here. So there are different kinds.
If you can sum it up.
Yeah. So there are different kinds of quantifications that can be done. Eventually, we'll have this in the software, which shows, you know, how, as a distribution, how through the thickness, you know, how the polarization state changes. This is for, you can see, you know, the 5-year follow-up analysis for one LASIK and one post-smile eye, you know, how much they differ. And the implications of this in terms of management we'll know in the near future. So just to finish, you know, yesterday, Naren was asking if you can put one average scan. So we did this analysis at 4 o'clock in the night, where we put one average scan. So eventually these scans will look like this, where you have nice contrast between the aqueous and the cornea, and you can nicely see the Baumans layer white field. You know, if you want to believe me, in few cases we can even see the Desai very nicely. It's just a matter of a little bit post-processing and stability in the analysis.
Probably for a cornea surgeon, you should even, based on the retardation, you should even be able to see the Duas layer, because the collagen is collagen 6
if the Duas layer is an actual layer, so there is controversy. So I don't know in general what the community feels over here, but there's always a split.
But the collagen is different.
Yeah, I mean, it's a very thin layer, so we are going down to 1.4, and going down below has registration issues, and you know how well the patient is also able to fixate. So for doing, let's say, topography and layer thickness, we want to go faster. For doing collagen mapping, we have to go slower. So there are different scan protocols that we have implemented here.
Will the shadowing effects be the same as for the other OCT in polarized light?
Sorry?
When you polarize the light,
yeah,
will the shadow effects that we see when there is something in the cornea be the same?
It will be the same. See, if anything, if there is an opaque which blocks light, that will always be an issue. We cannot see below it. But you know, people have asked that, will your cross-linking outcomes differ if you use polarized light for cross-linking? So it's a point to consider. Yeah.
Thank you, Abhijeet. Thanks a lot. Somebody was asking, do you have the photograph of that whole machine which covers one room?
Oh,
yeah, it's really big.
Right now, it looks like a table with a lot of lenses and.
This thing, but I can show it to you later on, I think.
And this is how it would look. Basically, the retardation of your collagen fibrils. And when there is loss of collagen, you see red areas, just like how you see topography.
So because we can do all the way up to the sclera also, we can actually, we have an internal fixation also. We can ask the patient to look at an internal fixation, displace it, and then you can also image the region around the limbus. So you can image the incisions that you make for cataract also. And that will show how the wound is also healing up because of, you know, how the collagen is getting cut there. So it has been shown even in glaucoma surgery also, you know, how the healing is changing over a period of time between patients.